Just going to say this happens in a low-income country somewhere in the world to me. I want to tell you about a shift where I got punched in the face. Not metaphorically, not the paperwork really got me today, or management made a tough decision. Literally, physically punched in the face by a patient. And at the end of that shift, after everything I'm about to describe, I opened the handover notes and typed 2 words, good shift. And I meant every letter of it. This is that story. It started the way all great disasters start. Completely, quietly. Noon, broad daylight. I had just finished giving anesthesia in the operating room. Textbook case, smooth, no complications. Patient woke up exactly when they should have. The kind of case that makes you feel genuinely competent. Dangerous feeling. Never trust it. Now, where I work, the anesthesiologist floats between the OR and the ICU. So after my clean, uneventful case, I walked over to the ICU to help out. Voluntarily. Nobody made me. I want that on the record. I had barely pulled off my OR cap when my phone rang. Emergency department. We have a 40-year-old male, status epilepticus. Can you come down? He's a bit difficult to manage. A bit difficult to manage. Let me translate that for you, because in emergency medicine, that phrase has a very specific meaning. It means the situation left the building a while ago. We have tried everything within our comfort zone, and we are now calling you because your job description contains the words airway management, which by implication also means whatever this is. I said, sure. I grabbed my bag. I went downstairs. I was not prepared. Let me tell you about this man. 40 years old, 110 kilograms, broad, built like someone who had never once in his life thought, maybe I should take the lift. He was epileptic. Diagnosed years ago, medicated, controlled, until at some point a neurologist told him he no longer needed his medication, and so he stopped. No taper, no monitoring plan, no follow-up, just stopped. Close that chapter entirely. I want to be very careful here about professional courtesy, so I will simply say that is one medical opinion I do not share. He also had obstructive sleep apnea, significant nasal congestion. In other words, like as the airway number said, the thing I specifically exist to manage, was already what we call in precise clinical terminology a project, and he was in full tonic-clonic status epilepticus, meaning he had been seizing continuously for long enough that this was now a medical emergency, not just a medical event. The emergency team had already given him 2 ampules of intramuscular diazepam. For context, that dose of diazepam in a normal human being produces a state of sedation that borders on general anesthesia. People don't argue with that dose. People sleep through that dose. In this man, essentially no effect. He was seizing like the diazepam had personally insulted him at a family gathering. I walked in and assessed the scene. 1 nurse on the legs, 2 nurses attempting, and I cannot overstate the heroism here, to get IV access, and the patient, all 110 kilograms of him, actively, vigorously preventing this from happening. Despite being in a seizure, his body had somehow found the bandwidth to multitask. I weigh 80 kilograms. I mention this purely as context. I took the right arm. Now, what followed was medicine. I want to be absolutely clear about that. This was a clinical intervention. I was applying therapeutic positional restraint to facilitate vascular access in a critically unwell patient. I was also functionally arm wrestling a man twice my effective body weight while wearing scrubs. The arm went everywhere. I adjusted, it went somewhere else, I adjusted again, and at some point, and I am not proud of this, but I'm also not proud of it, I transitioned into what I can only describe as a standing arm bar. The kind of hold that in a different venue would have a referee involved and a crowd. In this venue, it gave 1 nurse a clean, stable shot at the antecubital fossa. She got it. IV in first attempt. I think about that cannulation with genuine, lasting admiration. Propofol went in. The seizing slowed, then stopped. The whole room exhaled. The kind of exhale that happens when everyone realizes they've been holding their breath for 90 seconds without noticing. Someone's glove had torn. Someone else had a bruise forming on their forearm that nobody brought up. I had lost a pen at some point during the proceedings. These things happen. We don't dwell on them. And also took to a few pretty substantial hits. Head CT, clear. No bleed, no mass, nothing obviously sinister. Clean scan, reassuring, and also in its own way unhelpful, because if there's nothing on the scan, you still don't know why. We moved him to the ICU, IV benzodiazepines, added valproic acid, textbook management, the seizure activity settled on monitoring, and then he woke up. Now, post-ictal patients emerging from major seizures, are usually confused and passive. They come back slowly, like someone surfacing from deep water, disoriented, cooperative in a vague, compliant kind of way. You get a bit of time with them before they're fully back. This man did not do that. He surfaced like he had an appointment, and we were making him late. Within seconds, no transition, no groggy phase, nothing. He began attempting to dismantle the ICU bed. Not figuratively. He grabbed the side rail with both hands and pulled. The bed moved. It turns out the bed is bolted to absolutely nothing. This is information I now have. He was also communicating loudly in a manner suggesting significant dissatisfaction with the ICU, with us specifically, and possibly with the general concept of being alive in a hospital. We deepen the sedation. Richmond Agitation Sedation Scale, 0. That is the correct clinical decision, and also, I'll be honest, a tremendous relief. The room went quiet. I stood there and thought, okay, clear CT refractory seizure, stopped epilepsy medication years ago. This should be fairly straightforward from here. Then I called his mother. She picked up immediately. I introduced myself. I explained the situation calmly and professionally. Her son was stable in the ICU, seizure controlled. He was resting. She said, "Oh, yes, he's had headaches for the past week." I said, "I'm sorry." Headaches every day. He works in a factory, industrial glue production, has done for years. The nasal congestion is also chronic, just so you know. I wrote this down. I wrote all of it down. Then I asked if she could come in. She arrived 40 minutes later with documentation. I need to describe this documentation. It was a physical stack of papers, approximately half a meter tall, possibly more. Every medical encounter this man had experienced since he was 2 weeks old. The visits, specialist referrals, prescriptions, test results, discharge summaries, organized in a system that suggested his mother had been preparing for exactly this phone call for the better part of 30 years. She placed it on the nursing station. She looked at me. She said nothing because she didn't need to. The stack said everything. I looked at the stack. I looked at her. I looked at the stack again. "Thank you," I said. In the way you say thank you when what you mean is, this is going to be a very long afternoon, and I had hoped to eat at some point. Now, our hospital runs a 9-panel urine drug screen. Standard, you get what you get. And what we got in this case was a positive for THC. Cannabis, traces of it, in the urine. I want to be medically precise here. THC can lower the seizure threshold. It is a real pharmacological consideration. In a man who had already stopped his epilepsy medication, who was breathing industrial solvents 40 hours a week, who had been getting daily headaches for a week, it was one data point among several. A piece of the puzzle, possibly relevant, probably not the whole story. His mother received this information differently. The case was closed. It was the weed, she said, with the absolute calm of someone who had just had a 30-year suspicion confirmed by science. He must have gotten laced weed. That's what caused this. Someone sold him something. I began to explain the broader clinical picture, the epilepsy history, the medication, the industrial solvent exposure, the headaches. She looked at me. It was a very specific look, the look of a woman holding half a meter of documentation who has just been told by a junior doctor that perhaps the situation is more nuanced than she thinks. I finished my sentence. I want the record to show that I finished my sentence, and then I documented everything, ordered everything, and moved on with my clinical reasoning, internally, quietly, and entirely alone. She was not wrong that laced cannabis exists. She was not wrong that it can cause harm. She was simply not considering the rest of the evidence with equal enthusiasm. We agreed to disagree in the sense that I agreed with the medical picture and she disagreed with everything except the part about the weed. He recovered overnight, slowly, correctly, on the right medications. By morning, the picture was stable. The working diagnosis held. We felt reasonably good about it, and then the police arrived. Not for our patient. Adjacent to our patient, geographically adjacent. They had gone to his building. I don't know exactly why. I don't know exactly how. And I made a point of not asking too many questions because some information is best received in very small doses in the ventilation shaft of his neighbor's apartment. His direct neighbor, the one sharing a wall, they found 8 kilograms of cocaine, 8 kilograms hidden in the ventilation shaft. I want to be very clear, I am not suggesting there is any connection between the neighbor's cocaine and our patient's refractory status epilepticus. I am simply noting that he had been breathing the air in that building every day for years, with significant nasal congestion that his mother had described as chronic. I am not a toxicologist. I am not an investigator. I am an anesthesiologist who got punched in the face on a Tuesday. But I did stand in the ICU for a moment and think some thoughts. Long, quiet thoughts, the kind you don't write in the handover notes. He recovered fully, as far as I know, left the ICU on the right medications, with the right follow-up plan, and one would hope, a new living arrangement. The working picture in its final form, a man with undertreated epilepsy, working in industrial solvent exposure, breathing building air that was, at minimum, adjacent to 8 kilograms of cocaine, who had been getting headaches for a week, who then seized so hard that 2 ampules of diazepam barely touched him. His mother believed it was the weed. I don't know what the truth is. That's the honest answer. Medicine doesn't always give you a clean ending, just a working hypothesis and a patient who went home. What I know for certain is this. I received 2 punches to the back, 1 to the abdomen, and 1 clean and committed to the face, all during the armbar phase. None of them intentional, all of them very, very felt. And I wrote in the handover notes, good shift. I meant it, because a good shift isn't one where nothing happens. It's one where everything happens. The seizing, the wrestling, the half meter of paperwork, the toxicology report that raised more questions than it answered, the police, the ventilation shaft, the 8 kilograms, the punch to the face, and at the end of it, the patient is still alive. He left alive. That's the job. I have more stories. Some of them are medical. Subscribe if you want to hear them.